Good evening, everyone, and Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Muna Barakat. I'm Associate Professor in Physiology and Therapeutic Immunology at Applied Science Private University, in addition, Assistant Dean of Scientific Research and Graduate Studies at the same university. And as well, Editor-in-Chief for our journal, which is Jordan Journal of Applied Science Private University. And I'm here happy to be the moderator for this session. This is the same or the first lecture for our series. This series will be in collaboration with our prestigious collaborator, Journal of Pharmaceutical Policy and Practice, which is hosted by Professor Zahir Babar. So I'm happy here to be with you and with our brilliant Professor Dr. Nancy, Professor Nancy Hakkuz. So at the start, before introducing the lecture and the lecturer, I will take you for one small visit for our journal. Our journal is Jordan Journal of Applied Science, which was established in 1999. So we have two branches, humanities and natural sciences, and both they are indexed in multiple databases. And we are happy to start this webinar series just to make sure that we are truly visible, and we really appreciate your support for our journal, which is about to be Scopus indexed, inshallah. Now, as I mentioned, this webinar and this series will be conducted in collaboration with our brilliant collaborators, Journal of Pharmaceutical Policy and Practice, which is founded and managed by Professor Zahir Babar. I will tell you about Professor Zahir. Professor Zahir, he is a professor of clinical pharmacy and practice at the College of Pharmacy, Qatar University, and a visiting professor at the Department of Pharmacy, University of Huddersfield, United Kingdom. He has authored over 340 papers and is regarded as a leading researcher in pharmacy practice research category in both Google and Scopus ranking. He is a founding editor-in-chief for the Journal of Pharmaceutical Policy and Practice, which ranked Q1 on the Scopus, and having a high impact publication providing an evidence-based insights and recommendations for policymakers, practitioners, and researchers. Of course, the CV of Professor Zahir is truly impressive. He is passionate about advancing quality, equity, and sustainability of healthcare systems and improving healthcare outcomes for people around the world. Professor Zahir is supposed to be with us for opening remarks, but unfortunately, for certain conditions, he's unable to join us at this time. Hopefully, at the end of the presentation, he will be with us. Let me introduce our brilliant speaker today, Professor Nancy Hakkuz. Professor Nancy Hakkuz, she is a professor at the University of Jordan since 2012. She attended her BSc in pharmacy from the same university and her PhD in drug metabolism and pharmacokinetics from the University of Manchester, UK. She was the founding dean of the Faculty of Pharmacy at Zarqa University, in addition to the position of vice president in the same university. Professor Hakkuz has impressive, of course, biography, but I will tell you a small things about Professor Hakkuz. She received a prestigious award for the outstanding achievement in xenobiotics research by scientists from an underrepresented nation, International Society for Study of Xenobiotics 2022. And she was also awarded in 2013 the Best Scientific Research Award at the Zarqa University, Jordan. 2019 and 2022, she's got two opportunities for Erasmus staff mobility, one for the Bath University at UK and the other in the Lincoln. Over the years, Professor Hakkuz, she has been an outstanding example as a female researcher a team builder, administrator, academic, and mother, and truly a role model. Starting with me, my role model, and for others. Professor Hakus, the floor is yours, and we are happy to listen from you. I stop sharing and let you share your screen.
Can you see my slides?
Yes.
First of all, I would like to thank you, Professor, inshallah, you're going to be a professor, Muna, for inviting me to speak about one of my passionate things that I feel about in pharmacogenetics and personalized medicine. To start off, I would like to thank ASU, and thank you first, and then ASU, Jordan Journal of Applied Sciences, and the Journal of Pharmaceutical Policy and Practice for giving me this opportunity to present a very important and emerging discipline in pharmacy. When again, we're talking about pharmacogenetics and personalized medicine. Now, before I start discussing the topic, I would like to ask a couple of questions. And I want you to keep these questions in your mind while I'm doing my presentation. So the first question is about precision medicine. Is it the future of personalized medicine or pharmacogenetics? And the second question is about what is similar between these two things? What is similar between a parachute and pharmacogenomics? And I would like you to keep these two questions in mind while I'm talking about the personalized medicine and pharmacogenetics. And there are two things that I also want to address, very important issues. One of these is how effective are common medication? When we talk about the drugs, are all drugs effective? Do they perform as we expect all the time? Now, in a publication in 2015, and I think it is something that can be echoed these days, not all medications are effective when we talk about common medication. At the same time, when we discuss adverse drug reactions, we know that certain drugs will have adverse drug reactions. And it is estimated that around fourth or sometimes it is the sixth most common cause of death worldwide. And this is basically, we're talking about different types of reasons for comorbidities. We're talking about in heart diseases, cancer, and stroke. And basically, adverse drug reactions, it is one of the reasons why we have hospitalization, and again, why we have sometimes it might lead to death. So this is the reason why precision medicine has started. Precision medicine basically is talking about optimizing drug efficacy and minimizing adverse reactions. And I'm sure that all of us at the end of the day as healthcare providers, this is what we aim for. It's optimizing drug efficacy and minimizing adverse reactions. So exactly what do we mean by precision medicine? Now, precision medicine is an emerging approach for disease treatment and prevention that considers something called individual variability in genes, environment, and lifestyle of each person, for each person. And we find different terminologies whenever we talk about personalized medicine or precision medicine. It can be called stratified medicine, individualized medicine, genomic medicine, or even sometimes we call it the pharmacogenomics. Now, when we look at the different, let's say, expression of this, sometimes it is called the P4 medicine, where we're talking about personalizing, predicting, and preventing, and participate in the medicines in general. Also, it is called the concept of the 5 R's, where basically we're talking about the right drug at the right dose, at the right time, for the right patient, and for the right disease. So basically, we're talking about all of these, more or less, are talking about the similar discipline. So personalized medicine, precision medicine is discussed a lot these days. Is it a new concept? Is it something that we don't know about? Actually, it has been there for a long time. For example, when we talk about blood transfusions, we know that blood transfusions are personalized medicine. We cannot give any type of blood to any person. We have to make sure the type of blood that we want to give to a certain person basically is the right type of drug. And this is, again, the concept of personalized medicine. So we're talking about blood transfusion, but actually, a concept of personalized medicine started way before that. We're talking about Pythagoras, 510 BC. Now, Pythagoras had a very weird obsession of fava beans. Now, we know that some people have a certain type of, let's say, allergies, or if you want to talk about certain genes that are defective. And this is what we know as favism these days. But at the time of Pythagoras, they didn't know the favism, but he knew that fava beans are not good for everybody. So this is, again, he believed that we should never eat fava beans because they give us gas, and expelling gas took away the breath of life. And he thought, at the same time, he claimed that fava beans contain the souls of the dead. And he didn't eat fava bean or even allowed his followers to eat fava beans. And he's the one that said, basically, people react differently for fava beans. So we can see that the concept of personalized medicine, not everything works for everybody. And this has been, as I said, it is something that has been since Pythagoras. Fast forward, if we come to the recent years, now we have a physician, William Osler. He's a Canadian physician, and he was one of the first people that started talking about variability. And he was saying that variability, this is one of his quotes, that it's the law of life, as no two faces are the same. So no two individuals will react alike and behave alike under what's called abnormal conditions, which is, again, with the disease conditions. So he was saying that because no two faces exactly the same, if we look around us, we look at the different people, we can see that we are quite different in terms of our expression, in terms of the way that we look. And again, this is the concept of variability. So you can see that it has been there for a long time, but again, it has been, let's say, addressed more in these days. So when we talk about precision medicine, or again, personalized medicine, we're talking about approach that will more accurately predict, not even predict every type of, let's say, variability that we have. It will predict which treatment and prevention strategies for a certain particular disease. Again, when we talk about precision medicine, we're talking about prevention, we're talking about diagnosis, and also we're talking about treatment. And when we talk about treatment, we know that the way that everybody is treated these days is something called one size fits all, which means if we have a group of patients with the same diagnosis, we will give them the same type of drug with the same dose. And we would expect that everybody will have the same type of pharmacological activity. And this is not true. When we look at this is the traditional medicine, we can see that some people will have success. Basically, we have the pharmacological activity that we want. Others might have no effect, and others might have adverse effect. And this is traditional medicine. Traditional medicine talks about one size fits all. So if you have this person with the suit that fits him very well, why do we expect that this suit will fit everybody the same way? Again, this is what's called the traditional medicine. So traditional medicine has been evolved into something called personalized medicine. And personalized medicine, basically, we're taking all of the things that might affect the inter-individual variability in the different individuals in terms of pharmacological activity, and we look at exactly what dose we can give to these individuals. Some people will respond to the normal dose. Others might require a lower dose. Sometimes we might need to have something called a higher dose, maximize the dose, or sometimes you might need even to change the drug totally. And this is basically our role. We want to achieve the maximum efficacy with the lowest toxicity. As I said, this is the concept of personalized medicine. And again, we're talking about the inter-individual variability in drug response. So in a recent review article, they discuss all the different reasons why we might have inter-individual variability in drug response. And you can see some of these are physiological. For example, we're talking about sex, age, race. Others are related to the environment. But I want to draw your attention to these things. Genomic variants in something called phase 1 genes, genomic variants in something that's called phase 2 genes, genomic variants in transporters, and these are important for the pharmacokinetics of drugs. And we have mutations in drug proteins, which is, again, the pharmacodynamics of drugs. So inter-individual variability, drug response, it's not only related to the environment, it's not only related to physiological factors, it might also be related to genetics. And when we talk about these different genetic variants, we're talking about either changes with pharmacokinetics, we're talking about metabolism, we're talking about drug transporters, or we're talking about pharmacodynamics, we're talking about drug targets. So we are pharmacists, and I'm sure that most of us will know what the difference between pharmacokinetics and pharmacodynamics. Pharmacokinetics basically is talking about the concentration of the drug in the plasma. And this is the concept of something called ADAM or ADME, where basically we're talking about the absorption, distribution, metabolism, and excretion. Now, all of these will affect the disposition of the pharmaceutical compound within a certain organ. So ADME influences drug levels and the kinetics of drug exposure to the tissues, and hence influence the pharmacological activity of the drug. So this is the concept of pharmacokinetics. Now, when we talk about the difference between kinetics and dynamics, kinetics is basically what our body does to the drug. Again, absorption, metabolism, distribution, and excretion, while dynamics, we're talking about what the drug does to our body. And these are basically, can be influenced by the mutation or genetic differences in the individuals. So ADME stands for absorption, distribution, metabolism, and excretion. So the M stands for metabolism. So what do we mean by metabolism? Metabolism is a chemical change. It is a biotransformation of the pharmaceutical compound or substance by enzymes in the body, which basically will get them eliminated more easily. The whole idea is to change the drug to make it more water soluble in order to secrete the drug. And whenever we have alteration in the drug metabolizing enzymes, it might affect the drug response. And this is important because it will affect the kinetics. And as I was saying, that the kinetics is important because it will determine how much of the drug will be presented to the enzymes or presented to the site of action. Now, the majority of the metabolic processes inside our body are basically happens inside the liver, and the liver is involved in the metabolism of most of the drugs in general. So again, when we say ADME, we see metabolism for the M, and the metabolism happens by a chemical change. So what kind of chemical changes we might have? What kind of chemical changes might happen to drugs in general? Now, in general, we have two phases of drug metabolism. Phase 1, reactions, and these are called functionalization reactions, where basically either a functional group is introduced to the drug or a functional group is exposed. So we have xenobiotics, anything that is strange or foreign to the body, oxidation, reduction, dealkylation, and hydroxylation, where basically the metabolites will be presented to phase 2 reactions. Phase 2 reactions, we're talking about conjugation reactions. Again, once we have the metabolite, they can be attached, conjugated with endogenous substances to increase their water solubility. So in general, we're talking about two phases. Phase 1, which is the functionalization reaction. Phase 2, we're talking about the conjugation reactions. Now, one of the most important enzymes or enzyme family, whenever we talk about the phase 1 reaction, is cytochrome P450. Now, cytochrome P450 is a super family of enzymes. We have so many enzymes where basically these are important when we talk about the functionalization reactions. Now, cytochrome P450 is a superfamily that exists inside our body for our own metabolism. So they are important for endogenous metabolism. They oxidize steroids, fatty acids, and at the same time, they oxidize what's called xenobiotics. Now, when we say xenobiotics, as I said, xeno means something foreign. So xenobiotics, basically, they can be either environmental factors or pollutants, pesticides. They can be synthetic polymers, drugs, food additives. All of these are foreign. So our body basically recognizes these as foreign and tries to get rid of these by the different metabolic pathways. So as I was saying, in mammals, these are important for endogenous metabolism and also the metabolism of xenobiotics. And they are important. They are protective enzymes for the importance for the clearance of various compounds, as I said, for example, endogenous or exogenous molecules. Now, cytochrome P450 is a superfamily. Because it's a superfamily, usually it is conveniently arranged into families and subfamilies. And the way that we organize them based on their amino acid sequence similarities or identities. For example, if we say CYP3A4, CYP stands for cytochrome P450, 3 for the family, A for the subfamily, and 4 is the actual enzyme or the individual CYP. So again, when we say CYP for the cytochrome P450, 3 indicates the family, and when we talk about A, it's the subfamily, while 4 indicates the individual cytochrome. So again, this is the reason why we do this, just to make it easier for us to understand these different enzymes or superfamily of enzymes. Now, as I was saying, that whenever we talk about the drug response, our inter-individual changes that we might have in drugs in general, they are affected by many factors. As I was saying before, lifestyle, we're talking about disease states, age, weight, BMI, all of these are important for the inter-individual variability in drug response, and genetics. So why? Why is genetic is important whenever we talk about drug response? When we talk about genetics and its important its importance for drug response, we have to remember the again, what we talk about central dogma of biology. Now, the central dogma of biology, as I am sure you remember, this is basically basic biochemistry. Central dogma of biology says that every little information that we need is present in our DNA. And it is going to be, again, it's going to be transcribed into RNA, and the RNA is going to be translated into protein. So when we talk about the central dogma of biology, we're talking about, again, everything is found on the DNA, which is going to be transcribed into messenger RNA, which is going to be translated into a protein. And proteins are important. They play a very important role in the kinetics and the dynamics of drugs. Now, why? Proteins are responsible for the absorption. They are responsible for metabolism. They are enzymes. Active secretion of drugs is also a part of the activity of the proteins. So many of the targets of the drugs are proteins. We're talking about receptors, enzymes, transporters. All of these are proteins. Again, because the proteins are important in the absorption, the metabolism, and the active secretion of drugs, many of the targets of our drugs are proteins such as receptors, enzymes, and transporters. Again, genetics is very important. Now, if we have genetic changes, we have variations, mutations. A mutated protein might have an altered function. And if you have altered function, it might lead to altered drug response, which means less activity or more toxicity. And this is the whole idea of why we're talking about genetics. So just briefly to remind ourselves, are we quite different when we talk about mutations? Now, if we look at the different individuals, we can see that we are quite different. We have different faces. Our skin color is different. Our hair is different. Now, how similar are we to each other? And how different are we at the same time? Now, if we talk about genetic similarities between humans, it's around 99.9%. Any two humans, they share 99.9% of their DNA. So why we are different? The reason why we are different, because we have differences of around 0.1%. We can understand how important is this 0.1%. And this is important because, again, it will dictate the differences between humans. Now, in terms of what? In terms of height, eye color, skin tone, mental differences, personality differences, and also health and diseases. All of these are influenced by this 0.1%. Again, it's important not only for these, also for the drug response. Changes, small changes, mutations in the proteins might lead to differences in drug response. So we think that we have 0.1%. How can we have these differences? Where do these differences come from? Now, we know that most of the germline variations happens by different ways, something called single nucleotide polymorphism. We have what's called insertions or deletions, which are called indels. We have something called SCRs, polymorphic short tandem repeats, and we have copy number variation, CNVs. All of these are different reasons why we have variation. Now, the most important one, something called single nucleotide polymorphism or SNPs. Now, single, we talk about one change in the sequence of the DNA. So single nucleotide polymorphism, it is, again, they cause around 80% of all the sequence variation that are present in a gene. Now, we know that depending on exactly where the SNP happens, we might have certain changes, drastic changes. For example, we might have a stop codon instead of the enzyme or the protein itself or the amino acid itself, or we might have sometimes the changes will not affect the protein or the function of the protein. So it depends what type of changes that we have. Now, again, it is the predominant form of variation within what's called pharmacogenes, not only all genes, but also pharmacogenes. We're going to talk about pharmacogenes in just a bit. And by extension, the most frequent genetic variation in humans. As I said, this is not the only reason why we have changes. We talked about different types of changes, SNVs. We talk about indels. We have, again, deletions, insertions, and all of these are genetic variation. There's reasons for genetic variation, but the most important reason is SNP. So single nucleotide polymorphism, or the SNP, basically we have one single difference between genomic sequences. Now, when we talk about one single change, it will lead to sometimes drastic changes in the activity of the enzymes. An example of this is one of the most important enzymes in the metabolism of certain types of drug. Now, this is called thiopurine methyltransferase. Now, TPMT is important for the metabolism of 6-mercaptopurine. Now, 6-mercaptopurine or azothioprines are used for the treatment of leukemia, especially we're talking about childhood leukemia. Loss of the activity of the enzyme, loss of the function TPMT alleles, leads to severe toxicity of purine analogs, which might lead to the death of the cancer patient. Now, the activity of the TPMT is influenced by the presence of SNPs, where they exist. Again, at least we have 24 TPMT alleles. Again, the effect of the SNP depends on what type of changes might happen to the protein itself. And by this, we can introduce the concept of pharmacogenomics. So when we say pharmacogenetics or pharmacogenomics, what do we mean by that? Now, pharmacogenetics or pharmacogenomics, it is a discipline. It's a field of research that studies how person's genes basically affects how she or he responds to diseases.
Professor Nancy? Professor Nancy? Professor Nancy, your internet is unstable. We can't hear you.
Pharmacological activity of the drugs. Now, the first person that started discussing pharmacogenetics. Now, he was called Frederick Vogel. In 1959, he was the first person to link genetics with the pharmacology. As I was saying before, Pythagoras, and we talked about William Osler, everybody was talking about variability and changes and differences between individuals. But the first person our first scientist that talked about or used the word pharmacogenetics was Frederick Vogel. So why do we need to know about pharmacogenetics? Why it's important to know the effect of genes on the pharmacological activity of the drugs? Now, they found out that around 5 to 40% of the inter-individual variation in drug response can be attributed to genes. So genetics can explain inter-individual variability in around 5 to 40% of the different drugs. Well, again, we're talking about the effect of pharmacogenetics on the activity of the different enzymes. And because we want to discuss pharmacogenetics, we have to introduce certain concepts which are very important in order to understand the effect and the importance of pharmacogenetics. So I want to introduce a few concepts when we discuss pharmacogenetics or pharmacogenomics. Now, pharmacogenetics and genomics are a bit different from each other. Genetics is talking about single gene effect on the drug. Genomics is talking about whole genome. That whenever we use omics means big data. When we say pharmacogenomics, we're talking about the effect of DNA, the whole DNA. When we say transcriptomics, we're talking about whole RNA. So again, omics basically means we're talking about all the DNA that's present. Now, these days, they are used interchangeably. Pharmacogenetics and genomics are used all the time. Now, one of the important concepts that we need to introduce whenever we talk about pharmacogenomics, something called pharmacogenes. So, what is a pharmacogene? It is a gene that has one of the important following rules. Again, I want to emphasize that whenever we talk about the kinetics and the dynamics of drugs, we're talking about proteins. Proteins are important for the disposition of the drugs, and they are important for the dynamics of drugs. So it is associated with the drug's mechanism of action. For example, we have the BKRC1, which encodes an enzyme targeted by warfarin. Warfarin targets this enzyme. It's also involved in the metabolic transformation of drugs. Again, we're talking about metabolism. We have CYP2D6, for example. It's important for the metabolism of a lot of prescribed medication. And they are important for the transportation of drugs. For example, we have the ABCB1. This is a transporter protein, and it is important. It is important for moving various medication between different compartments of our body. So if you want to say what is exactly a pharmacogene is a gene that encodes a protein active in a drug's pharmacokinetics or pharmacodynamic pathway. This is what we mean by pharmacogenetics. Pharmacogenetics, at the end of the day, we are studying pharmacogenes that will give us the differences between the kinetics and the dynamic pathways of the drugs. Now, because we're talking about genetic variants, we have to remember that whenever we talk about cytochrome P450, for example, we said that CYP stands for cytochrome P450. 2, for example, the name of the family, A, the subfamily, 6 is the actual CYP, actual enzyme or the gene. And we have something called the star alleles. The star alleles, basically, they describe the different variants of the actual gene. For example, if we talk about CYP2A6 star 1, this is the wild type. Then after that, all the different variants, depending on when they were discovered, basically they will be designed star 2, star 3, and star 4. So when we talk about the star alleles basically it is a standardized system for nomenclature of pharmacogenomic alleles. For example, again, when we say CYP2D6, CYP stands for cytochrome P450, 2 for the family, 2 for the subfamily, and 6 for the actual gene. Star 2, we're talking about the different alleles. Again, CYP2C19, star 17, we're talking about, again, CYP2C19 is the actual gene, allele 1 star 17, allele 2 star 17. Because we know that our DNA basically comes, half of it comes from our parents, mothers, and then half of it come from our fathers. So we have something called diplotype. Each, again, allele is present on one of the strands of the DNA. So just to emphasize what I was saying, so again, CYP3A4 star 2. Again, CYP stands for cytochrome P450, 3 for the family, A for the subfamily, for the isoform itself, star 2 is the gene number. Again, this is the way that these are standardized in order to understand the effects of these different type of, let's say, variants or genes. Now, another important concept. What is the importance of knowing these star alleles? Now, because this can be translated into what's called metabolizer phenotypes. For example, if we take CYP2C19, how can we translate the genotypes into a phenotype? So when we talk about phenotypes, we have, for example, for the CYP2C19, we have something called ultra-rapid metabolizers. These individuals, basically, they metabolize the drug in a very fast rate. We have the regular metabolizers, or sometimes they're called extensive metabolizers. Sometimes we have something called normal metabolizers, and intermediate when they have a low activity, not very low, but intermediate activity. And we have the poor metabolizer when somebody has what's called the two non-function alleles of the CYP2C19. So it is a wide range of, let's say, activity when we talk about the metabolizer phenotype. It's starting from very, very low metabolism. We're talking about poor metabolizer up to very high concentration of the activity of the drug, and we're talking about ultra-rapid metabolizers. Now, the ultra-rapid metabolizers sometimes, because the concentration of the enzyme that will be synthesized will be higher, and sometimes certain alleles will lead to high expression of these proteins. So is it always the same? When we have ultra-rapid metabolizer, does it mean that our body will get rid of the drug faster? It depends. If we're talking about prodrugs, things are different. Now, because we have a prodrug means it is a drug that is presented to the body in a form that is inactive, which again needs to be activated by metabolic pathways. For example, we have codeine. Codeine is given to individuals, and usually this is activated in the body by CYP2D6 activity. Now, if you have high function of the CYP2D6, basically you will have increased concentration of the active drug, which is the morphine, and this lead to higher morphine concentration, which might lead to certain side effects. While we have no function allele, for example, it will lead to no morphine being formed, and this will not lead to the pharmacological activity that we want, because we give codeine in order to be metabolized into morphine. And this is exactly the opposite when we talk about active drugs. Now, if we talk about active drugs, for example, TPMT, as I said before, if we have the normal function TPMT, means that the drugs will metabolize. The concentration of the drug that is presented to the body will be lower. At the same time, if we have no function allele, this will lead to high risk of hematological toxicity because of the increase in the concentration of the active drug. And again, it depends. Again, if we're talking about the differences in the how these drugs, again, that are metabolized inside the body, either they will be activated or they will be removed from the body. So this is important because whenever we talk about the dose selection based on the genomic profiling, basically we say that for metabolizer phenotype, they will require a lower dose. Intermediate metabolizers, or again, normal metabolizers, they will require the normal dose, while extensive metabolizers might require a higher dose. It depends again on the different drugs and the type of side effects we might have. So what is the value? Why is this important to understand? What is the value of pharmacogenomic testing? Now, a lot of the studies that have been conducted around the world basically explains the importance of the pharmacogenetics. So what is the importance of pharmacogenetics to physicians, for example? For physicians, they will prevent 20 to 30% of adverse side reaction or drug reactions. A lot of the studies that have proven that if we have pharmacogenetic testing, it might lower the adverse drug events or reactions by 20 to 30%. Now, it is known that around 99% of patients, they will have at least one actionable genetic variant. And when we say actionable genetic variant, it means that we can base a certain clinical finding on this actual genetic variation. Now, 7.6% improvement in medication adherence because people will not have side effects and they will be more adherent to the drugs in general. What is the importance of this for patients? Now, for patients, it saves money on medication. Because sometimes we're talking about when we give a drug and the drug does not work for a different individual, what can we do? Basically, we can, whenever we talk about medication, if the drug will not work, why spend money on that drug? Basically, this is the whole idea of the saving money for the patient. And it reduces something called medical trial and error. I'm sure that a lot of you knows that sometimes we can give a certain medication with a certain dose and it will not work, or it might cause side effects. And at the same time, because of these, we might need to either lower the dose in order to lower the side effects, or we might need to increase the dose in order to have a certain efficacy. One big example is warfarin. And I'm sure that you know that warfarin, usually it is monitored by something called INR, when not all patients will benefit from the same dose of warfarin. And sometimes you might need to administer a certain dose, wait for a few weeks before we decide if this is the right dose or not. So again, all of these are benefits whenever we talk about the benefits of pharmacogenetics for physicians, or we're talking about for patients in general. So do we have to do this for each drug? Is it important to have pharmacogenetic testing for each drug that we prescribe for different individuals? No, it depends. Now, not every drug we can do the pharmacogenetic testing and we get the benefits we want. Now, the pharmacogenetics is not the magic solution for every problem that is related to the pharmacological activity of the drugs or if we have side effects. Now, the drugs that will benefit from pharmacogenetic testing, we have drugs with narrow therapeutic range. For example, we're talking about thiophanate. Now, when we say narrow therapeutic range, it means that we might shoot to the toxic concentration or be below the effective concentration quite easily if we're talking about the metabolism or the different metabolic pathways of the thiophanate, for example. Drugs with life-threatening adverse effects, for example, 5-fluorouracil. Now, we can easily do the pharmacogenetic testing for individuals and then decide what kind of dosing we should give for these individuals. Again, drugs, therapies, which again, response can be badly predicted. We're talking about antidepressant drugs. And I'm sure that sometimes, you know, that when we give antidepressants, we might require at least 3 months before we actually have an effect. If we know that this drug is not effective in this individual, why wait for 3 months until we get a certain pharmacological activity? So antidepressant drugs but also can benefit from pharmacogenetics. If we want a quick response, if we talk about analgesic drugs, we gave an example of codeine and morphine. So if we want a certain activity, certain pharmacological activity, we want quick response, pharmacogenetics can help us in that matter. Now, when we talk about where we use pharmacogenetics, it is used a lot in oncology. Again, the reason why we're talking about oncology, because we're talking about a very, let's say, with side effects, a very important toxic drugs with side effects, certain drugs, behavioral health, we're talking about antipsychotics, cardiovascular diseases, and also in the pain management. We might require pharmacogenetic testing in general. So if we want to summarize the things that we discussed until now, what are the goals of pharmacogenetics? we want to maximize the drug efficacy with minimum drug toxicity. And this is important because this is what we aim at as healthcare providers. We want to individualize treatment. We don't want to give the same dose for different individuals. We want to optimize the dose. We want to reduce the trial and error instead of waiting for a week or 2 weeks or a month or 2 months before we know if the drug is going to work or not. We can give the exact dose from the beginning. Again, we can predict patients who will respond to our drug, because sometimes certain patients might not respond to the drug at all. For example, when we talk about codeine, if a patient is CYP2D6 poor metabolizer, he cannot or she cannot metabolize the codeine to morphine, and they will not respond to drugs. And the hope is, this is what we hope for. We hope that everybody will have their own passport where it contains all his or her genotypes, and they can present this for the pharmacist, and the pharmacist can prescribe the best drug for that individuals. So we can see that pharmacogenetics is very important. Now, why it is important? Because we can, as I said before, we can personalize medication and get the maximum effect for individuals with the minimum side effects. So this is important. Where do we find information of pharmacogenetics? How do we know that this drug might be influenced by the metabolic pathway that will be influenced by a certain allele or genetic variation? Where can we find information? The best place to find information is through research. And basically, we cannot always have we cannot always do the research. We can't do the research, all of us at the same time. So we need resources. We have pharmacogenomic resources where basically they contain information. When we go to these different resources, they contain information that will tell us exactly the kind of changes that we need to do to a certain drug. And these consortiums are present all over. Now, most of these consortiums that are presented on this slide, basically there are freely available consortiums where basically we can go through these different consortiums and get information about the pharmacogenetic importance of or let's say, pharmacogenetic variants of the different drugs. And as I said, these are important. These are free. We can go to these and we can get all the information that we want. Now, if we talk about the personalized medicine, drug therapies, different consortiums, web-based pharmacogenetic consortiums, we have the FDA, the US FDA, the Food and Drug Administration. We have something called the PGRN. This is the Pharmacogenomic Research Network, or the Pharmacogenomic Global Research Network. We have the PharmJKB, Pharmacogenomic Knowledge Base. We have something called CIPIC. CIPIC is the Clinical Pharmacogenetic Implementation Consortium, and we have other types of consortium all around the world. Some of these are, let's say, European. For example, we're talking about the Dutch Pharmacogenetic Working Group. We have others that are found in Asia, and we have others that basically are important for standardization for the different elements. For example, we're talking about PharmVar. Now, we don't have the time to discuss all of these. I'm just going to give you a taste of these, two of these consortiums. We have the FDA, the Food and Drug Administration. Now, the FDA has what's called Table of Pharmacogenetic Association. Now, this table of pharmacogenetic association, if you open the table, you'll find a list of drugs with the genes, the different genes, our alleles, affected subgroups of these genes, and what kind of interaction, what kind of change that might be happen when we have the gene, let's say the defective gene or the mutant gene. And the table of pharmacogenetic association is important, and it is updated all the time. And this is one of the reasons why this is an important consortium. Now we have CIPIC, which is the Clinical Pharmacogenomic Implementation Consortium. CIPIC stands for, it's a consortium that is developed to translate the genomic research results into clinical guidelines. CIPIC contains guidelines, clinical guidelines, which are available again, depending on genetic tests that can be done for different individuals to optimize drug therapy. If we go through the CPIC, for example, if we open the CPIC, now CPIC has, again, same thing. It has the different drugs, and it is telling us exactly what kind of changes might happen to the drugs depending on the alleles that we have. We also have the FARM-JKB. FARM-JKB stands for Pharmacogenomic Knowledge Base. Now, it is a comprehensive resource for gene-drug interactions. Now, the FARM-JKB, it curates, basically takes the different gene-drug information. It processes these different information from different resources, for example, FDA, the CPIC, other consortium, and an updated databases of pharmacogenetic studies. It looks for the data from published research. And if you open the FARM-JKB, you can find a small paragraph talking about the importance of the FARM-JKB. But for example, we are going to take example, for example, we talk about warfarin. In this case, it is telling us about warfarin. It will give a drop down menu where we can look at different indications for the warfarin. We have, for example, if we talk here, this is a prescribing info to find the published pharmacogenetic guided guidelines, where basically it depends on research that's published. If we look at this part, for example, it will talk about the list pharmacogenetic related drug labels according to the FDA and the EMA, which is the European Medication Agency. And this will give us, for example, the annotations, where after the curation, we have the annotation. This basically will give us exactly what to do about the different variants of the individuals with the drugs. What are the changes that needs to be done? And the FARM-JKB is, again, it takes all the information from the different consortium, and after curation, which is processing, it will give us a level of evidence. Now, as we go from level 1 to level 4, the evidence basically is lower. So whenever we talk about FARM-JKB and a very strong evidence, we're talking about level 1, A and B, or level 2, A and B. And all of these basically is done by scientists in different disciplines, mainly pharmacogenetics, where they can take the different research findings from the different consortiums, and then they decide what kind of evidence is present. And basically, this is done periodically. We have periodic changes in the annotations or in the level of evidence. If we have a new research, a stronger research, the level of evidence will rise. And sometimes the level of evidence might go down if we have another research that will tell us, no, there is no big association between this gene and this. So we can see that we have different resources whenever we talk about the different gene-drug interactions. But the whole idea, can we follow the information that is presented by these different consortiums in Europe? And can we basically follow this information in our countries? Are we the same? Are we different? We found through research that there is an interethnic variation in drug response. Again, we cannot always depend on what is the variants that were discovered in Europe and say this is basically the same in Jordan or in the Middle East or in Asia. So they are quite different whenever we talk about the interethnic variation in drug response. And we need more research in our countries in order to decide what kind of variants do we have. And do these variants affect the drug response or they don't affect the drug response? So we can see that pharmacogenetics can explain a lot of side effects. Sometimes they can explain why certain medication will not work in certain individuals. So how can we do the pharmacogenetic testing? What kind of approaches do we have for the implementation of pharmacogenetic testing? Now, in general, we have three different, let's say, implementation approaches. One is called preemptive. Preemptive, basically, we do the actual tests before we prescribe the drug. And after we get informed about the allelic frequency or the variants that are present, we can prescribe the drug. Usually the testing are completed prior to the starting of the medication. Now, most of the times, the way that they approach the pharmacogenetic testing is something called reactive. Whenever we say reactive, there is an action and reaction. Reactive means whenever we have a side effect, inadequate response to a certain, let's say, a certain drug, we might do what's called reactive testing. We test for the different variants. And sometimes we might have what's called point of care. At the same time that the drug is prescribed, we can take a sample and do the genotyping. And at that, when we get a variant that will inform us that the drug will not work or will have side effects, we might change the drug in the future. So these different approaches, basically, it depends on the different types of the drug. It can be either done, again, actively or reactive, as I said, or preemptively before we actually prescribe the drug or at the point of care. Now, saying all of this, what kind of conclusions can we get when we talk about pharmacogenetics? Now, there is a paradigm shift. There is a shift from one size fits all medication into what's called stratified medicine, and this will lead to precision medicine, depending on the different environmental factors, on the disease of the individual, on the genetics of the individual, we can prescribe the drugs. And the whole idea is to reach the maximum drug efficacy with the lowest side effects. So when I started, I posed a question. I said, precision medicine, is it the future? I hope I could convince you that the answer is yes, it is the future. Now, the current way that we prescribe medication, one size fits all. If we have the different individuals with the same diagnosis, we give them the same dose of the drug. And this doesn't always work for every individual. Some people will have effect, others might have no effect at all, others might have adverse side effects. And we want to go for, this is the future of the medicine, going for more personalized diagnosis. Again, when we take everything into consideration and then we decide the dose of the individuals. Either we increase the dose, either we lower the dose, or sometimes we might need even to change the dose or change the drug totally. Saying this, if you go back to history, we started saying that Pythagoras talked about fava beans, and he has the important, or let's say the famous quote that people react differently to fava beans. To William Osler, that discussed the variability as a law of life. To Boga, which basically talked about pharmacogenetics. And he was the first scientist that used word pharmacogenetics and related genetics with the pharmacology. Now, despite the promise that it will give us safer and more effective drug choosing, the incorporation of pharmacogenetic testing in clinical practice is still very slow. Now, why? Why is it very slow? If we discuss the reasons, the challenges that we have, we know that we have a lot of challenges whenever we talk about pharmacogenetics. For example, we talk about testing and the implementation. It is costly. It is getting cheaper, but it is costly. And again, a lot of the time, the pharmacogenetic testing is complex. We have limited research on diverse population. As I said, most of the published work is in European ancestry, in people from European ancestry, so it might be different in different countries. Lack of standard tests and knowledge. We have a high gap of knowledge in the healthcare providers, not only the pharmacists, also the physicians. We have to have more knowledge, more, let's say, We have to lower basically have more education in that part. So these can be, again, they can be solved. These challenges can be solved. Now, whenever we talk about the expenses, as I said, as the technology is getting better and better, the cost is getting less. Again, a lot of the advances that we have in pharmacogenetics is related to advances in technology. Now, if you're talking about a diverse population, we need to include more individuals, more diverse populations in our genetic testing. We need to do more research. If we're talking about the gap in knowledge, we need to include pharmacogenetics as part of our teaching. We're talking about not only for pharmacists, also for the physicians. So these challenges can be resolved. We have solutions. And again, as I was saying, the pharmacogenetic is not the magic solution for everything, but it is the future. The future is here. Basically, we're talking about more individualized medication. And this individualized medication depends, again, on the different individuals. Again, I was talking about the differences between individuals, the variability between different individuals. And this basically will lead to more personalized medication, more personalized medicine. And this is what we want. We want the maximum side effects with lowest side effects or lowest toxicities. I also started our presentation with similarity. What is the similarities between the parachute and the pharmacogenomics? Both of them work. We don't need research in order to understand that parachutes will work if somebody is skydiving, because we will not do the research and see somebody, we throw somebody from the plane and would they come back to Earth without any problems? No, we need to have working parachutes in order for this to happen. Same thing with the pharmacogenetics. Pharmacogenetics is a solution for a lot of things. We don't need more research to basically to convince everybody that it works, but we need to have implementation more in the pharmacogenetics. And by this, I thank you, and I am happy to answer any questions.
Many, many thanks, Professor Nancy, for this comprehensive, fruitful presentation. It was really enriching for me, myself, and I believe for others. Truly thank you from the bottom of my heart. So before taking the question, please let me pass the mic for Professor Zahir. He would like just to have like small remarks at this time. Professor Zahir, can you join us? I'm not sure if he's hearing. Professor Zahir, yeah.
Yeah.
Oh, thank you very much, Dr. Mona. And I would like to welcome you all to this JoPPP webinar series. This is the first time Journal of Pharmaceutical Policy and Practice has sort of joined in organizing a webinar series. So it's our great pleasure that Dr. Nancy has sort of inaugurated this. I really enjoyed listening to this fantastic presentation. Thank you very much, Dr. Nancy Hakus. And thank you to Dr. Mona and Applied Sciences University to collaborate with Journal of Pharmaceutical Policy and Practice to launch this webinar series. And today is really important because this is the first time we have this, and this is our first session. But I'm sure, I'm very confident that under the leadership of Dr. Mona, we will have very, very exciting sessions to come over. So thank you very much once again, Dr. Mona, Dr. Nancy, and all the participants who have joined us from around the world. Thank you. Over to you, Dr. Mona.
Thank you, Professor Zahir, for these remarks. And truly, we are humbled with this collaboration. And I'm lucky to start with the Professor Nancy. It was really a very great start. So hopefully our next lectures and webinars will be at the same level. So I will start with the questions and not to make it long for the audience. Now, we have a question from Sarah. Do we predict that pharmacogenomics will be an economically viable approach in Jordan in the near future? And from this question, I would like to ask Professor Nancy related. question, where do we stand in the Middle East regarding the personalized medicine and pharmacogenomics?
We don't have pharmacogenomics in clinical implementation, let's say in Jordan, but if we're talking about Arabic countries, we have differences in different Arabic countries. It's not part of, let's say, normal practice of clinical implementation of drugs, but it is done. For example, we're talking about oncology. We have pharmacogenetic testing. For example, in Egypt, they do a lot of oncology testing, let's say pharmacogenetic testing, before they give the different types of drugs. In Jordan, we have a certain way of personalizing oncology, because we know that people, they take al-khuza, which basically they take a biopsy, and then they look at the different, let's say, cells and what kind of drugs they will respond to. And then they will prescribe that drug to the individuals. But they don't take this further. Now, once we know that this is the actual drug, we have to know, is this drug is going to be toxic for that individual or not? And we don't have that. We don't have the next step for doing this. So in terms of clinical implementation, no, we don't have a clinical implementation. It is only done for research purposes. Now, most of the work, whenever we discuss the pharmacogenetics, this is research-based. It's not a clinic, it's part of clinical, let's say, normal clinical implementation. Now, regarding the question of Sarah, yes, I think it is going to be an economically viable thing to do. Now, when we talk about the drugs, we talk about not every drug needs pharmacogenetic testing. The drugs that needs pharmacogenetic testing, as I explained in my lecture, usually those that have very, let's say, very high side effects, or we might not reach the exact pharmacological activity that we want. And these drugs usually that we need to do the pharmacogenetics for, instead of having certain period of time, taking a certain drug and it does not work for a certain individual, or if we have side effects that might require hospitalization. Now, this is the minimum of side effects. Sometimes side effects might lead to death, especially when we talk about certain types of oncology medication. So I know that if we want to convince policymakers, the best way to do it is to convince them that's going to save money and save lives. But it is going to be part of a normal clinical, let's say, implementation. I'm not too sure when. Is it tomorrow? Is it next month, next year? We're hoping. And I am hoping that if more and more individuals, more and more education that we have, we talk about pharmacists, we talk about physicians, if they are convinced that pharmacogenetics can be a solution for certain types of medication, I'm sure it's going to be implemented. This is what our hope, Dr. Amuna, that pharmacists, our students are the pharmacists in the future, and they will be in a place where they will have an effect on policymaking. And this is what we want. We want everybody to be convinced it's not a magic solution. It's very important. It's not a magic solution. It is a solution for a lot of, let's say, the pharmacogenetic testing can be a solution for certain drugs. And in terms of economics, testing is getting cheaper and cheaper by the day. Technology is getting better. And this is important whenever we talk about the importance of pharmacogenetic testing in the future.
I believe that, Professor Nancy, as you say, that the presence of the technology and now the presence of the AI will accelerate the acceptance and the establishment of the personalized medicine and pharmacogenomics. I do remember when we were students, we did not hear about detailed pharmacogenomics or this concept, but nowadays, most of the curriculums have this approach on this module. So it's just, I believe it just become much more cultural and much more sounds than before.
Yeah, so, and something else something else, Kaman Muna, we have to remember that whenever we talk about pharmacogenetics, we don't need to do genetics or pharmacogenetic testing every time we give a drug. We only need to do it once. And a lot of the times when we do pharmacogenetic testing, it's a panel-based, which basically means more than one gene can be tested at the same time. And it stays with individuals.
Yeah.
Our genes will not change in our life. It's different than when we do, for example, a CBC. When we do a CBC, it's a snapshot of the time where we did the CBC. It might change with time, but our genetics, our genes will not change. So we only need to do it once. Once we do it, we can be informed of our genes. And that can be, this is what we were saying, this can be our passport for the future. For example, I'm saying, we always say about side effects, we concentrate on death or hospitalization, but side effects can be very minimal. For example, it can be, for example, if we talk about myopathy for people that use statins, it can be explained quite easily by a certain mutation and transporter, and it can be done by a simple tests. We can know, we can be informed that this individual, when they take statins, they will have side effects. This individual will not have side effects.
And with the presence of the predictive models and establishment, it would be much easier than before.
Yeah.
I do believe that, but before that, it should have like a reactive approach that you mentioned. But now, with the presence of the detective models and one sample, to have such a databases, you can solve the problem permanently. So hopefully we will reach this hope and this passport soon.
Yeah.
We have another question. From Rawand, how will widespread adoption of pharmacogenomics impact the drug development, regulatory approval processes, and the business models of pharmaceutical companies?
It will improve. We're talking about different drugs. If we talk about drug development, now if we develop certain drugs, and basically we know, according to one of the requirements when you register a drug in the FDA, the US FDA, you have to do metabolic profiling for the drug. And when you do metabolic profiling, it will tell you what kind of enzymes will metabolize these different drugs, what kind of metabolites we might have. So in terms of development, we can use our knowledge of the different variants to predict that this drug will have certain side effects in the future. So drug development depends a lot on the pharmacogenetics, or at least it will depend on pharmacogenetics in general. We're talking about drug companies, pharmaceutical companies. They will have much easier task of understanding how these different drugs might affect individuals depending on the genetic variants that we have. Again, it depends on the actual drug that's developed. Would it have a pharmacogenetic implication or not? But it is a way of, let's say, this is one of the things that can be done in the future for drug development to inform different pharmaceutical companies on the way that the drugs will perform and what kind of side effects, what kind of doses we might need to give for different individuals. I think it's the future. But again, have to emphasize, this is not a magic solution. It is part of the solution.
Okay. Great. Thank you for this comprehensive answer. I believe that this is the most of the questions, and I want to thank you from the bottom of my heart again, Professor Nancy, for this great lecture. And in addition, our audience, they thank you as well. So hopefully we will see you again in the next webinars and to keep in contact with you. Thank you everyone.
Thank you for hosting us. Bye.
Thank you.
Thank you.
Have a good night.
Bye. Assalamu alaikum.
Assalamu alaikum.